Thanks, Vivek.
Thanks, Beth. Hi, my name is Vivek. I'm currently an ED doctor in Royal Darwin Hospital Emergency Department. So it's 11:35. So good morning from Darwin. And I think in most other places it's a good afternoon. Pula Vinaka. When Beth asked me to talk about a topic, it was very opportunistic because I just had gone through quite a bad resus and just trying to do a bit of soul searching as to why it went wrong. So I thought to talk about communication in resus, which was more of a revision for me. So I just looked at some facts, and this data is based off a study in 2004, which looked at some 2,500 events that went wrong, or sentinel events, and it was shown in that study that 70% of those events happened because of communication failure, and 3/4 of these patients basically in this cohort actually passed away. So close to 500 patients actually, just over 500 patients actually died because of lack of communication, directly or indirectly. So I'll just talk about some of the reasons why communication failure happens, what would be some of the strategies we could use. And I think a lot of this is going to be reiteration, because you probably, if you're in the health facility or whatever work you're doing, you're already doing this. Like I said, this was more of a revision for me as to how I could put a bit more structure into my own communication, and how I could actually have a better outcome for my patients. The importance of closed loop communication is especially essential in resus and sort of high stress environments. I'll talk a little bit about how we can escalate communication. This is sometimes a bit difficult in the Pacific setting, considering that words of verbal communication is not the only aspect of communication in the Pacific. There are some nuances with body language as well. And then what are some of the command types that you could use to actually deliver the message that you have? So on my first ever shift at Royal Darwin Hospital about 2 months ago, I was working in sort of a short stay unit, starting as a night shift. And I was told by the team leader, we've got someone who's intoxicated, was stabbed in the chest. The blood pressure initially was 110/70, GCS was 14, and en route, the patient, on the way, the patient's blood pressure became 85/50, heart rate went up to 110, and the saturation came basically is 95 on 5 liters. And this person is 5 minutes away. So I was just told while I was taking handover. So in the emergency department at this point in time, it was 11 o'clock at night. This is our handover period where the evening staff's going home, night shift's coming on. So I was on a sort of a low acuity area, and I was just told by a phone call, just need to get to resus. There's something coming in. Go and have a look and see what happens. In the background, the resus bay got emptied out, and a trauma call was done overhead, and it said 5 minutes away. On that day, there was a locum consultant who has been here for about 2 weeks now. I've never met him before. He designated the senior registrar on that night shift to be the team leader for that resus if it did happen. So it seemed, the picture that I got from everyone at that point in time was that there was no real concern by the registrar, and they thought the blood pressure was not really concerning. Whilst I rocked up into the resus room, the surgical registrar was there already. There were no other consultants except for the registrar, who was also going to be the team leader. I was told by the nurses had actually done their role allocation. So they had their stuff together as usual. And I was concerned about airway, breathing, circulation. So I thought might need a chest drain, might need to look after the airway. So we got equipment nearby, but nothing had been opened. I was a bit worried about the scantiness of the doctors that we had, about what we were going to do. With this particular surgical registrar, he was a pretty junior registrar. He had never done a chest drain in his life. So he did not want to be involved in any procedures he had set up front. Now, the patient then arrived into the emergency department, into the resus bay. This gentleman was talking. If you wake him up, he was still drowsy, quite intoxicated. He had a blood pressure of 103/75, with a heart rate of 120, saturation was 95. I did the primary survey at this point in time, found a 1 centimeter laceration on the chest wall in the front, and brought out the rest of the primary survey I was happy with. And I did a bedside ultrasound scan, which showed a clot around the heart. He did not seem to be in tamponade, seemed to have just been a clot just puffing around, not really under pressure. About so in this period, we realized he had only one IV line, so we wanted to get a second IV line. The team leader, who is now the consultant, had taken over the team leader role and said, "Oh, I'm going to put in the cannula." I said, "Sir, I think you just need to go do the team leader role." He said, "No, I'll put the cannula. I'm the best person at doing this." And in all this furfiness, the blood pressure now has come down to 80. Now we're worried that this person is going to collapse. We already know what the reason is. It's blood around his heart, and it's probably putting pressure on the heart itself. And he's probably going to go into a tamponade if nothing is done about it. So we gave a liter of fluids. We gave a liter of fluids as a bolus, and the second IV line, like I said, was being put in by this locum consultant at the moment. And there was a decision to do a thoracotomy in the emergency department. Now, this ED consultant asked around the room who had done a thoracotomy before. Two of the consultants there said, "No, we've never done one before." So me and another ED consultant said, "We'll do one side each." And we brought out a thoracotomy tray, and it was opened up. Now, this person's GCS is still about 13 and 15, between 13 to 14. His blood pressure is 80, yes. And now the ED team leader, the consultant is saying, the locum consultant is saying, we need to do a thoracotomy now. And I said in a very low pitched voice, I think I'm not ready to do it because I'm afraid he will have a bit of pain. And the consultant said, "No, we need to do it now. We should get onto it." And then after that, after the thoracotomy tray was opened,
let's get started. The first way to get to a Zoom meeting is through an invite link, which can be found inside the body of an email invitation. Like,
we've got some feedback this end. Can you make sure you're all on mute, please? Perfect. Thank you.
sorry about that. Yep. So thankfully, not thankfully, there was something missing in the thoracotomy tray, which was just a pair of scissors to open up the chest. So someone started looking for it. And then the locum consultant said, "Oh, we need to give some more fluid." The airway nurse started to ask about medications. Another nurse was asking about if we need to give some more fluids. And I think by this time, the nursing team leader, The nursing team leader was done. She screamed across the room. She's like, can everyone please shut up? And can we decide who the resus team leader is? Everyone just stood still for 10 seconds and looked at each other. And I know this team leader, so I was like, good call, Kathy. Let's look after the airway. At this point in time, the surgical consultant walked in. We've got a blood pressure still of 80. We've got someone in tamponade. He made the decision, let's take him up to theatre, with the few of us looking after the airway and giving fluids as we go up. The patient was moved to theatre. The patient actually had a good outcome. Had like a half a centimeter lack on the left ventricle, which with some clots around the pericardium, which was evacuated, and it discharged about a week later. This is probably the first thoracotomy I've been involved in where patient actually was discharged. Now, 1 week later, this locum consultant came on shift again, and he apologized to me, and he said, that is probably the worst ever resus that I've done in my life. And I was like, why is that so? And he's like, oh, we've never actually done a debrief about it. And I was like, yeah, we should. So on that shift, we got a few people together, including the nursing team leader, one of the other registrars. We talk about what happened and what went wrong. I tried to tell him about all the cues that I was trying to give, that we need to look after the airway before we do the thoracotomy. He basically said he did not hear me, and he didn't think that that was a concern for him. He didn't think it was urgent. He was very focused on doing the thoracotomy. We did dodge a potential catastrophe in the emergency department. Now, putting thoracotomies into context, just yesterday I was told by one of our ED consultants, we possibly do more thoracotomies in Royal Darwin Hospital compared to most of the trauma hospitals in Sydney. I think we've done about close to 8 this year now. So I think the trauma service would probably be well versed with it. Not all of them have good outcomes, but just because the amount of penetrating chest trauma that we have in Royal Darwin Hospital and in the Northern Territory, that's why we have those statistics. Now, then I started to ask about why did this go wrong, or what could I have done differently that could have actually improved this outcome, or have done a better resus before. I've worked as an emergency doctor in Fiji and a few other places for almost close to 10 years now. I've definitely been involved in quite a few resuses, being a team leader or being also a team member as well. And I was very concerned, being so senior, that why I couldn't contribute so positively to this resus. And so I started to sort of look into what was the reason I didn't do so well and how I could have helped the team. So looking at communication strategies and why the communication failed, the first thing that I thought about was the physical constraints, which was the noise, which was clearly a problem. There were too many people talking at once. There was no smooth communication. Everyone was trying to get on top of each other's voices. The second thing was hierarchy. I'd never met this consultant before. I did not know his name. I did not feel comfortable sharing my opinions with him. And hence, I felt I could not talk to him. There is also linguistic or cultural differences that could also make a difference. Now, I come from the Pacific, and to talk over someone who's more senior or more in charge is just not in our culture. We tend to use a low tone voice and then say that, oh, excuse me, I think we ask more of a question as opposed to give a statement or sort of say, hey, this is what we need to do. We tend to do that less, and we're more of a, shall we do this, or ask questions. The use of jargon is also seen as one of the reasons of communication failure. Now, everyone on the team may not be well versed with some of the jargons, that the medical jargons that exist. And then there are, which I've discovered personally, is, and I don't mean to discriminate against Australia, but people coming up with their own jargons, which is not world renowned, and essentially that sort of puts you off guard and just says, what is this talking about? Am I dumb for not knowing this? Being a team leader or being a team member, if you start to focus on tasks apart from what you were allocated to do, then you could fail to communicate or just lose that sight that you need to talk about this or you need to tell this. Some of the other reasons is, again, being a senior person who already knows what's going to happen, you have this biasness, or you think that you know what's going to go wrong. So, but you want this other person to know, but you're too afraid to say it, with possibly because of hierarchy, or possibly because in your mind, you know, this is going to go the wrong way. Now, how can we do it better? How could I improve this resus, or how could I have done better at this resus? I certainly did not share my mental model. No one in the room said out loud, we've got someone who's going to arrest very soon because they've got a clot or bleeding around their heart, and this is what we need to do. A safe environment was not established. Maybe this was the first time ever I sort of saw the value of introducing myself, or the other person introducing themselves to each other, and understanding that, and just putting it out in the open and saying, this is what I want to do, this is what my skill is. If you have any questions or suggestions, please tell me, or please communicate with me. That statement, I reckon, is very powerful. Allocating tasks and roles. I think everyone in this room probably already knows the value of that. Allocating tasks and roles to a particular person, that basically puts you in charge of what you're going to do, what you will be looking after. An airway team will be looking after airway issues. Vascular, of the person who's going to be looking after circulation will be putting in cannulas or giving drugs, so on and so forth. Now, if the information flowed through one person, it filters through the person who actually has got a bird's eye view. So whatever I have discovered in my little team, if it went through the team leader, then it could possibly be a sort of a light bulb moment for him to understand, oh, this is what I need to do. This is what possibly could happen now. Now, remaining objective is a difficult thing sometimes. We can have our own emotions, having a bad day that day, or just having a bad experience from before, take away objectivity, and you become subjective about that particular incident. You can also have PTSD or trauma from the previous resus or previous incident, which essentially you put yourself in the center of what's going on. Therefore, you forget about the patient in front of you, and therefore you kind of lost the battle. This is a human thing to do, though. We get caught in it at one point or another. Just trying to think that keeping the patient in the center of everything might help you, might direct you toward what's happening. Now, I'll talk about a case also at this time, which sort of brought out the strategies of communication in resus. In CWM hospital in Suva, there was one night where we had 4 asthmatics that we intubated, and by the fourth intubation, which was around 5 o'clock, I could not be team leader anymore because I was too tired. My brain had stopped working. I could possibly do one thing only, maybe just one task. So I asked the nursing team leader, who was Faith Cornelius, which some of you would know, to actually run run the resus or run the intubation. And the way she did it, even though she was not a doctor and was not a trained ICU nurse or an ICU person, she kept communication very clear. She kept checking with me, did all the ways of communication really well. And these simple things actually got us through. And I think out of the 4 intubations, that was probably the smoothest. And I think Faith that night taught me quite a lot about communication. I wish Faith was on this forum to listen to this talk. The 3 C's of communication: citing names, knowing people by their names helps. It adds that personal touch. It also gives you the clarity of your naming this person as to, hey, John, please give 1 milligram of adrenaline followed by a normal saline flush. So therefore, you've used the name John, you've given a clear instruction, and John, who has taken the information on board, will now close the loop after he's done it, saying, yes, Vivek, I'm giving 1 milligram of adrenaline as an IV push, and I've given 20 mils of saline, has been given, sorry. So just using the 3 C's again, the sender communicates, the receiver who receives the information takes the message, says that he's received it, and then he says it back to the sender. Now the sender then confirms that this has been done, and then the receiver now says, once the task is done, then says that the task is done. It's actually a bit more complicated. Now, I'll talk about something called graded assertiveness, which is an escalation of communication. This is something I failed at that night, and I thought about it. So there's a mnemonic called a PACE approach. So probing is trying to alert the person. Do you know that this person's blood pressure is now 80/40? And then if we still don't register, the person who receives the information does not register, and we can alert them by saying, can we please reassess the situation? This person's blood pressure is 80/40. Challenging is a bit more abrupt and a bit more, I wouldn't say confrontational, but just catching the person's attention a bit more. And the tone of the voice should not change, but essentially saying, please stop what you're doing, because this blood pressure is 80/40, we need to do an active intervention. And then emergency, you have kind of thrown the white flag in, you've tried everything, now you have to say, and maybe raise your voice as to saying, stop what you're doing, this is going to go really badly, let's just do this. Again, in the Pacific, we tend not to, we kind of stop at the alert bit. We don't like to challenge or yell out that that this is wrong. Okay. For the nurses, I know in the Pacific it can be a bit of a hierarchical thing, but in a resus or in a situation where you're looking after A, B, and C, the problems are usually pretty simple, and the interventions can be simple as well. So, and if A, B, and C is not looked after, the patient will die. I brought in some more statements that we can think about, like when you hint things, should sort of say that should things look like this? Should his blood pressure be 80? I think it would be wise if we considered why his blood pressure is low. Asking a question as well, what do you think we should do about his blood pressure? Or shared suggestion, sort of asking, both of you are taking sort of in charge or like responsibility of this thing. You and I should maybe do the following. You and I should look at why his blood pressure is low. Is he bleeding from somewhere else? Is he going into tamponade? And then the statement side of thing, I think we need to do the following. I think we need to take that clot out. I think we need to do a thoracotomy. I think we need to do some blood, give him some blood. And the command, again, we should do this now. We should do the thoracotomy now. So just heading back to the graded assertiveness, there is, I know definitely in the Australian culture, it does go down to, I have seen things go down to E, but in the Pacific, it was more difficult for us to actually go beyond that, beyond alert, especially if you got someone else more senior who's around you, like an anesthetist or a surgeon. And it was difficult even as nurses for them to speak up and sort of challenge or sort of press the emergency button and say, hey, we need to stop what we're doing. We need to reconsider what's happening now. I've talked quite a lot now. Do we have any questions? Or any of your own experiences?
Wow. Whilst we're waiting for potential questions, can I please, it's more of a, well, it is a question and a comment, I guess. What you explained there was obviously an extremely complex resus, and I think communication is probably one of the most riskiest things and dangerous things we do in healthcare. You know, we talk about all these complicated clinical things we do, like in thoracotomies, inserting chest tubes, doing 4 intubations in a night. But really, the actual dangerous thing we do is fail to communicate properly. And I think that runs wherever you work in the world. It's a common theme. Do you have any suggestions as to how, from a nursing point of view, how nurses may feel more comfortable in escalating concern for deteriorating patients?
I think there's several ways I've discovered. One is when I come on the night shift, I go to the team leader and I see what roles have been allocated. If I haven't worked with people, I introduce myself and sort of say hello to the nurses, whichever roles they're going to be in. That's kind of the first strategy. And I'm talking about night shift because that's the most dire times, and that's the most important time as well for me, I reckon. The second thing, which has been a bit difficult to do now in COVID times, is training together and doing simulations together, which the emergency department in Royal Darwin Hospital have stopped doing. They've stopped doing simulations with the nursing team now, so we're not in sync anymore. And also declaring, remembering that the most skilled person doesn't have to be the person doing the team leading role. Your team is going to be, you'll draw on your team for special skills, but essentially making sure that the team leader knows that they need to watch out for these things. So we need to empower the team leader as well as to watch out for the blood pressure, tell me if the saturation is low. It is kind of a team sport, is where you fill in the gaps. Everyone is not perfect. And it's just filling in the gaps as to where the lack is really. And I don't know if that answers the question.
Yeah, that absolutely answers my question. Thank you. Has anyone else out there got any other questions or comments for Vivek? Or if you don't feel comfortable in unmuting, you're more than welcome to type something in the chat.
Vivek, it's Erica. I just wanted to say thank you. It was a really, I think, honest and frank appraisal, and I think it's so important when we can share those times where things don't go well as the times that they do. I'm sure you've had many resusces where it's gone really well. So I hope you also remember those ones and reflect with as much self-criticism on the ones that go well, because you know, they're not all the challenging ones. But thank you. I think that I certainly learned a lot from that, and I think it's the silver lining sometimes of when things don't go well, isn't it? That we can learn from it.
Yeah, there's a stupid saying I have. Good judgment comes from experience. Experience comes from bad judgment. And you're right, Erica. I actually remember all the resources that have gone wrong, or the people that I've lost. Right from the first one in the emergency department. I can tell you all the details of my first resource that went wrong on my first night shift when we had only one doctor on night shift. It is obviously a good time for self-reflection, but that's why I brought out Faith's case, where that research went really well and what I learned from it. So it's sort of just to balance out and highlight that good communication by someone who was not clinically senior, but just did the simple things, and we had a good outcome with a very tired doctor.
Thanks, Erica. Has anyone else got any questions or comments or stories to tell that they would like to share?
Hi, Dr. Vivek. This is Pranil. Just wanted to mention that I really love that about how you need to be specific and clear when delegating roles. I've actually discouraged my nurses and even the doctors in using that term "someone." You know, when we actually designate or allocate a role, and it's an important part of communication. When you say, can someone give 1 milligrams of IV adrenaline? And then you see, because there is an adrenaline rush already in that resus room, you'll see 2 or 3 nurses or even doctors running to grab that adrenaline. And yeah, it's like a bad word to say in ED here. You will not want to say someone. If you need to, and that's a very good point that you've raised, that you need to establish rapport with your team, and you need to know one's limitation on what someone is skilled at doing and what someone will not be able to accomplish. So thank you again for your presentation, Dr. Vivek.
Thank you, Pranil.
Any other questions? Welcome, Borges. How are you?
Thank you, everyone. It's good to see you guys. Thank you, Vivek.
How are you?
Thank you.
Good to see you.
Yeah, good to see you.
Yeah, it looks that way.
Have we got another question?
Hi, Beth. It's Matilda here. It's not really a question, but thank you, Vivek, for that clear presentation. You've mentioned very important points on communication resuscitation, which is a very important aspect within our different units or respective areas. And good way forward as well, like the PACE approach and all that you've mentioned. And in regards to, you mentioned culture as a barrier, which is we do experience that in our units as well. Like on daily basis, we do experience that kind of thing, like hierarchy and the Samoan culture as a barrier during our daily work.
Yep.
And sometimes it's, sorry to say this, but sometimes bringing that culture in doing patient care doesn't really help at times. But if we do really think about the safety of our patients, then we need to put that culture aside so that we serve the patient right. Like for example, during the ward rounds, we do have patients that needs to be transferred to other wards, but then at the end of the round, some of the head of unit, sorry to say that, but they decide to leave the patient in ICU without any good medical, clinical reasons. So that's the time we need to step up as nurses and do the right thing. We do experience that a lot in our units, but then we need to do the right thing so that we save the ICU space for our very critical patients. And it's a good reminder for all of us, especially us in the island, where we have limited resources, we have limited space in our units. A good team support during your resuscitation, and good communication is very important. It's good that one of the personnel there called for everybody to be quiet, which is very important, to speak up for the safety of the patient so that we can do our work smoothly to save a life. And even with you've mentioned that you were tired the other day and you delegated your role to someone. That is very good. Like if you felt tired and you gave your role to one of the nurses and it went well, that is very good. Even the 3 C's you mentioned, that's a good point as well. Within communication during resuscitation, it's a good daily reminder for all of us to set. Well, we are not perfect, but we need to set up things in advance for the safety of our patients. Thank you very much for the presentation, Vivek.
Thanks, Matilda. I'd just like to tell you, being in Australia for about 6 years, you are not alone as an ICU nurse. The battles are same in a well-developed country as well. They're handled slightly differently, but more or less they go through the same battles. And what happened that night in resus in Royal Darwin Hospital, it's a very well-resourced settings. We're not short of manpower at all, but we just didn't do the simple things really well. In terms of what happened that night at CWM Hospital, and Pranil will know this very well, we worked in very small teams, and in the Pacific, we are not very well resourced in terms of human resources. But doing the small things as a team, I knew all my nurses back and front. Essentially, we knew each other so well. We communicated so well. And whilst I was there, I tried to help that along by actually doing things outside the hospital, sort of doing team building exercises, doing lovos, or like having a kava session outside the hospital. And like we would go and this is going to sound wrong, we would actually party together and basically would play together as well. So it helped with team bonding, definitely. And those people who are not part of that team bonding exercise, you could see couldn't do the communication really well, and therefore that sort of would end up in not sort of, sometimes the outcome wouldn't be good. The cultural thing that you talked about, Matilda, it is a Pacific thing. It happens in Australia as well. Like I struggle with this other consultant simply because I'm from the Pacific, but other people from Australia also had a similar experience with him as well. So the problems are essentially, more or less the same. The solutions are more or less the same as well. Keeping the patient in the middle of this, what's the best outcome for the patient with the situation we have, with the resources we have. So keep up the good fight, Matilda.
Thank you.
there any other questions or comments? I'm not sure if Veronica is trying to.
Hello,
Hello, Veronica.
How are you, Veronica?
how are you?
Good. How are you going there in PNG?
We are doing well.
Excellent. Have you got a question for Vivek, Veronica?
No, not at the moment,
Okay,
but
Wait.
I enjoyed. We all enjoyed.
good.
Thank you so much.
Pleasure. Veronica, when
It's a
you
learning journey for us.
there might be a question from Nathaniel. Oh, thanks, Nathaniel. Great presentation. Thanks, Vivek.
Thank you, Nathaniel.
Absolutely, fully agree. Well, if there aren't any more questions, we might call it a day for today. And we will very much look forward to hopefully seeing you all next month. Yes, thank you. Before we go, thank you, Vivek. Would you all, if you can, be able to put your cameras on and so that we can take a photo of us all together, please? That would be absolutely awesome. How do I hide that? You can't, can you? Whoa, Ango, you've got a huge turnout. Oh my goodness. Basilio. We're just waiting for Denora, you're allowed to put your video on as well. Beautiful. And who is HEOC? Are you able to put your videos on? If not, no, don't worry if you can't. Now, Denora, are you able to take the photo? Oh, just squeeze in. Oh. All right, smile.
Oh, I'm still muted. Sorry. I tried to capture everyone.
Yeah. No. You happy to know?
Yeah, I'll just try to get everyone in the screen.
Okay. Cool.
Hold on. Sorry. Just one more.
This is it's like we're all models.
Okay. Nice.
Lovely. Thanks, Denora.
You're
All right.
welcome.
Hope you all enjoy the rest of your days, and we look forward to seeing you next month. Thank you. Thanks.
Thank
Vivek.
you. Thank you, Vivek.
Bye-bye.
Bye, Mackenzie. Bye, Mackenzie.
Bye.
Bye. And bye.
Leave me to